in order for us to know, basically, you have to know the basics. You know, one of the basics. I mean, like if you like, I'm here in LA. I don't know my points here, so I mean, you know, GPS is like I think one of the best man-designed or man-developed innovations of today, right? Because I can get from point A to point B because I can get my phone up and just plug in whatever the location, just hit directions, and it tells me where to turn left, where to turn right, whatever. If I make a mistake, it tells me go whatever a mile further and then make a right, whatever, whatnot, right? So this is the key to your surgery. You have to know where you're going, right? I mean, because there are vital structures in our body that we have to avoid, unfortunately, right? And so anatomy is the map for surgery. Unfortunately, you have to know it. You have to know it in and out. And so I'll start with the maxilla, top jaw. I mean, there's not much to the maxilla, basically. You have the anterior maxilla. In the anterior maxilla, you have the incisor canal. You have buccal concavities there, too, like especially canine premolar areas, even in the anterior regions, very anterior regions. And then the posterior maxilla, you have, like the bone is softer, and you have the sinus back there. And the sinus is just it's just an air-filled space. That's all it is. It's nothing special. It's just an empty space. That's nothing more, basically. So the anterior maxilla, you have the incisor canal, which is a nerve, basically, right there in the nerve. And so if you're extracting anterior teeth, sometimes I just get the needle and just drive it right in there, basically. And we inject right in there. If the incisor canal gets in the way during an implant placement, which it does a lot when you place 8 and 9, we cut it and we remove it. We remove it and we graft it, basically, and we place the implants. You can't leave it because if you leave it and your implant hits it, the patient's going to complain of pain because it's a nerve, basically. So you have to remove it. But there's no consequences to removing the incisor canal nerve, basically, because it doesn't innervate areas where they really have sensation in sense. But anyway, so like the concavity is there. So when we place our implants, we have to be careful that you're not outside the bone, right? So one of the basic principles of implants, which I'll talk about in more detail later, but we want it to be in solid bone. So this is one of the analogies that I tell my patients, like you need bone, right? You need bone to place implants. So imagine, like to guys, a lot of the guys, I say, if you're gonna hang a 100-pound mirror on your wall, right? Don't you want the anchor to be in the stud, right? So you want to make sure you find the right stud, and you want the screw to be completely in that stud, right? Solid stud, right? If you're like halfway in the stud, right? You hang that mirror or whatever. Over time, it may be stable right away, but over time it's got and they may fall, right? Same thing with the implant; it's just gonna fall, right? And then so same thing. If I'm not in the stud, I place my screw in the drywall. You hang that 100-pound mirror on there. It's gonna fall right away. Basically, it's not gonna stay. So bone is important, okay? Bone is important, and so you have to make sure that this is where CBCT is important too, so you can see stuff, because what you see in the mouth versus what you see in reality of the bone anatomy and structure is two different things. So buccal concavity, I mean, of course you can feel for it. You can feel for it with your finger, and so I say the finger is the poor man CT. I mean, I talked to Dr. Park during the surgery a couple of days ago. I say like the lingual concavity, I say feel for it, right? I use the finger all the time. I put my finger in areas to feel for structures that I know that, I want to be careful for, basically. So utilize it, don't just stare at it, but utilize it, get the feel of it, okay? And then also anterior maxilla has a lot of variations in the bone orientation and the teeth orientation. So anterior implants, I'll talk about more later, but it's more challenging, basically, because sometimes people have severe anterior flare, some people have less anterior flare, and some people have little anterior flare. And sometimes teeth are super buccal, sometimes teeth are right in the bone, basically. It just depends. And so this is why CBCT is so critical. This is why having the prior knowledge before getting into surgery is so important, basically. As I said, anterior teeth has a natural flare. It's just one of those things where teeth just have a flare, basically. You'd be surprised how much tilt there is in the teeth, basically. So like when we create the osteotomy, like on anterior teeth, we have to do it like 3 to 4 millimeters above the apex, basically, because of that flare and where the bone is situated. Did I not? I thought I changed my slide. Anyway, so posterior maxilla, bone is soft, it's D4 bone. But it's not always in the posterior maxilla. You have posterior mandible where the bone can be soft. And so this is why CBCT is also critical, because sometimes bone is very tricky. You don't really realize what you're getting into sometimes. But in the maxilla, we have the maxillary sinuses, and so I'll talk a little bit about the maxillary sinuses, okay? Because this is kind of important, because we always talk about, there's 4 different sinuses in the maxilla. You have the frontal sinus, the ethmoid sinus, the sphenoid sinus, but what's relevant to us is the maxillary sinus, basically, because that's the one that's going to get in the way. The other sinuses we shouldn't be dealing with, because if you're up in those areas, then you're in the wrong area. You're not. We shouldn't be in that area. So, what is the sinus? It's just an empty space lodged in our face, basically. It's partial, and it just communicates with the nose. That's all. So that's the most important thing, though. It communicates with the nose. Okay. And so for us, it's pyramid shape, basically. It's pyramid shape, and the pyramid actually points out towards the sides. Okay. The pyramid base of the pyramid is actually towards the nose. So this base here. This base is here inside towards the nose, okay? So that's just the anatomy of the sinus that you want to be cognizant of. And it's about 12 to 15 milliliters in capacity. And the dimensions is about 23 millimeters medial to lateral, the depth. And from anterior to posterior, it's about 34 millimeters. This is like the average size. And over time, it pneumatize, meaning that it enlarges. It gets bigger with time. And then you have some septus. Sometimes there's sinus septus in there that it helps to compartmentalize the sinus, basically. And so this is the anterior. So this is the front of the face here. Anterior to posterior is about 34 millimeters. And then from the medial wall, which is towards the nose, to the outside face is about 24 millimeters there, or 23 millimeters there. So. And it's not, the functions of it is not well understood. We don't really know why it's there. But it helps to decrease the head weight, basically, the facial head weight. And also, it might absorb some of the shock of the trauma because it's air-filled, basically. And so, the way how our voices come or resonate might be due to it, basically, depending upon the sinus. Because if you hear somebody that has a sinus congestion, you can immediately tell, right, when they talk, right? It's like their voice changes. And so that's one of the things that kind of, and we breathe in air, and it also helps to warm, humidify the air as well too. So that's one of the things that it does. So, but why is it relevant to us? So as dentists, as I talked about, when we need to, if we're going to place implants, right, it's going to be in the back. It has to be in bone. But unfortunately, number 14 is one of the teeth, like 6-year molars, are one of the first teeth to go, right, in the mouth, right, and sinus. It gets in the way. It just gets in the way, unfortunately, because as I said, we talked about the mirror and the stud, 100-pound wall, right? You want to be in bone, right? And unfortunately, the bone back here is softer. It's D4, D3 bone, and the sinus gets in the way, so you have less bone. So so it gets in the way. So that's why it's important to us. So we need to know how to manage it, basically. So sinus augmentation is often required, but there's easier ways. Like a couple of days ago, the Cresto approach. It's like there's an easier way. There's newer techniques that just makes it easier, basically. And they're less invasive. And you have to know your limits, unfortunately. But this is where training, education, continuously striving to get better and better. You gotta work hard. It's like if you want to get fit, you can't expect to get fit in one day, right? You have to kind of. And those guys, like I see people. I don't really exercise too much, but those people that train, they're training constantly, right, all the time. So if you want to get better, you have to keep working at it. So once again, pyramid shaped, okay? So the roof of it, the superior border is towards the orbit of the eye. So we're not really messing with that area. Once again, if you're trying to go to the superior border of the sinus, you're in the wrong. We shouldn't be doing that, okay? So what's the most important part for us is the inferior border of the sinus, which is where the teeth kind of sit on, basically on top. And so once again, same picture, anterior wall and the medial wall. And what's really relevant to us is this medial wall, basically, because the ostium is like right in the middle, but it's high up. It's usually very high up, but it's the communication between that and your nose. That's the channel where you communicate through the nose. And because of that, then when we do sinus augmentations, we put particulate graft into the sinus, basically. And so there's what's called a Schneiderian membrane. It's a membrane that helps to keep everything sealed, basically. And the sinus is a sterile environment, basically. And so we're violating it when we do any kind of lifts and stuff like that. So bacterial contamination, or keeping bacterial contamination, is very limited. It's very key. Modern day antibiotics helps quite a bit. But you see these patients that have continuous sinusitis or whatever, it's hard to control, right? Because they can't get rid of the bacteria. So unfortunately, it's very important to do our surgeries like as sterile as possible, basically. And so this is why I mentioned about, changing the protocol to keep things more sterile, right? So that we don't contaminate the stuff. And so when even though our dental offices are clean, we call it a clean environment, sometimes you want to make sure that you're sterile, more sterile than clean, basically. And so, wearing sterile gloves, not touching stuff with your sterile gloves, number one, just and making sure that you're, working in a sterile environment is very key so that you don't contaminate to induce bacteria, basically. So the ostium is about it's like in the center, it's about 4 centimeters up high, okay? So it opens into the middle meatus, which is the nose, basically, your nose. And the actual opening is about the size of a standard implant, which is 4x10, but the tiny opening is only about 2.4 millimeters in diameter, basically. It does enlarge and shrink or whatever. But so what happens is, and you have what's called the mucociliary sweep, and so there's cases where we have sinus, during live surgical courses, we do sinus augmentations, and there's accidents where something gets perf, right? And then there's bone particulate in there. So we take a CBCT, and you see floaters, right? And then we take so we clean it out, and then we take another CBCT, and it's gone. Because it's already cleared by the mucociliary sweep, basically. That's how fast it clears things up. So it's very fast. It strokes at about 1,000 strokes per minute, basically. It sweeps things up. But the problem is that if you put large particulate graft material in there, and as it's trying to sweep things up to clear it up, basically, the body's trying to get rid of this foreign particle in there, foreign material in the sinus, you can block the sinus. If you block the sinus, they're going to have the congestion, the blockage is going to cause pain, pressure pain, and it's going to cause a lot of problems. So that's why it's important that that's why having the membrane intact during sinus lift surgeries is very key to success. So the sinus, that's how it looks like. And so if they do have a clog like this, if that happens, then you have to refer them to an ENT because they have to go through the nose to try and unclog it, basically. That's how they have to unclog it, basically. And so using, like small particulate material is very important, and making sure that you don't perf the membrane is another important technique. And so sinus augmentation procedures and stuff like that is more advanced, and so we can talk about that later, but I'm just going to go over the basics. And so, but this is one of the key factors that you want to keep in mind, to prevent. And posterior maxilla, it's usually D4 bone. It's like styrofoam. It's very soft. It's very soft bone. Is it always like this? No, there's always exceptions. I've had cases where some guys have super strong bone, it felt like almost like D1, D2 bone in number 14, 15 areas. So you just never know. But once you do enough osteotomy, once you do enough surgeries, you get a feel for it. You get to feel the bone. Like when you're doing the osteotomy, you can feel the bone. But CBCT, you can actually see it beforehand because you can see the trabecular pattern within the bone. So it makes a difference when you see that, So this is why having critical data before you jump into the case is so important. And then next is the arteries and veins of the face, basically. So you have the facial artery that feeds into the PSA artery and the greater palatine artery and the infraorbital artery there, basically, of the face. Why is it important? So in the maxilla, if you're doing, like the greater palatine nerve is right there, and the artery and the nerve runs in similar patterns there, basically. It's run side by side, basically. If you're doing like connective tissue graft where you're taking tissue from the palate, if you cut that artery, you have a bleeder. It bleeds, you can see the blood just squirting. It'll just go. And so when you first see it, and you have them opened up, it's very it's scary almost because you have this blood where it's just bleeding like crazy, right? So pressure and time will stop, but you don't want to cut it. I'm just saying, so you have to be careful. So you want to know where it's at, and it's usually like on average palatal vault. You've seen patients that have shallow vaults or deep vaults, or average palatal vault. It's about 12 millimeters from the crestal ridge there. So if you keep that in mind, and it's usually around where the third molar location is at, So if you avoid that area, you shouldn't be going that far. Usually when we do connective tissue graft, we stay in this region, right? So we go from here like this, and then we cut here, basically. So that's the reason why. But you want to be cognizant, because if you're going that far back, you're going close to the soft palate anyways, too. So you should never be that far back anyways. And also the nerve runs in proximity. We give PSAs, MSAs, ASAs, infiltrations for like 3, 4, 5. 8, 9, 10, whatever, all the time. So this is common for us. This is nothing special for us. So, but in the sinus also, you have these anastomosis branches that we call it, and you have these arteries that are embedded in the cortical bone, basically. And so they run. So this is relevant to us because when we create our window for our lateral window technique, for lateral sinus augmentation technique, it gets in the way. And so these are usually, they're small, but once again, they get cut when we do lateral window techniques. This happens all the time. And the blood, same thing, it just squirts. When you make a cut, it just squirts. You can see this like pulsating blood squirt just constantly going, right? So what you do, if that happens, once again, pressure. So we take a hemostat and just crunch the bone. And you have to really put a lot of pressure on there. You have to hold that there for like a good 2 minutes or 3 minutes or so. You have to hold that. You can't just let go after like a couple of seconds and expect it to stop, because these are a little bit bigger diameter. They're less than a millimeter, but they're still pretty decent size. And so if you see it like this, you can see this is pretty carefully dissected, but it gets in the way. And you can see it on the CT. That's why CT is critical before surgery, because when you see it, where you're going to create the window, you can see it on the CT. And so this is why information before surgery is critical, basically. And so here it says about half the time you can see it in the CT. The location where we're going to create the window, you can see it on the CT there, basically. But it's pretty high up. It's about 16.4 centimeters up from the crestal ridge. But that's not always the case, because a lot of times we're doing lateral window techniques because the bone they've lost teeth, they lost bone. So by the time we're in there, is in the exact location where we want to create the window. Unfortunately, that's what happens. So even though it's that high up, right? But it gets in the way. It gets in the way. And so crestal approach, like if you guys. I talked about posterior maxilla, you lose teeth, sinus pneumatizes, and so you get sinus exposure. And we talked about this a few days ago during the surgery, like, what happens if you're to the crest, So this bone here is usually a very dense cortical bone, okay? And so I actually sometimes go through the sinus because the bone in the posterior maxilla is D3, D4 bone. It's soft bone sometimes, and your stability of your implant is not the best with that soft bone. So I actually go through so I can engage that cortical plate, so I want good stability of my implants. So if you penetrate, it's not the big deal. If you perforate, even if you perforate, as I said, it's a sterile environment, so you don't want to introduce bacteria in there. But once your implant gets placed, it plugs it back up. And this membrane, let's just say you tore the membrane, this self-heals, basically. Within a week, basically, that'll heal. So it's not a big deal. As long as you're not introducing any kind of foreign material, like bacteria in there, basically. It'll just heal over the implant. And here, they've done studies. Even if it's less than 4 millimeters or above 4 millimeters, it doesn't really matter. Patients might get a little nosebleed because you're in the sinus, So that's one of the common side effects. And over time, if you take an X-ray, you might see some thickening of the sinus membrane, the Schneiderian membrane. You might see that, basically. But it'll usually self-resolve with time. So not a big deal if you do perforate. But that doesn't mean that you want to routinely just perforate the sinus. During the live surgery case, right? We went to the sinus, but we were very careful, and we purposely didn't perforate the membrane, right? And we even did a little crestal augmentation approaches, right? A couple of days ago. And so if you can, if you know the techniques, if you know how to do it, basically, you can always not violate the stuff. We still follow the basic protocols, right? And we still place the implants, basically. So